Hello and welcome to this video on acute pancreatitis. This video is a part of our series on surgical emergencies. I've made the pancreatitis videos into two parts. In this video, we're going to talk about the case, the etiology of how pancreatitis happens, the pathophysiology of pancreatitis happening, and then sequelae, what does pancreatitis lead to, and then its clinical features, which include the signs and symptoms, and finally the diagnosis. In the next video, I talk about the management of acute pancreatitis. So pancreatitis itself is a very diverse, is a very vast topic, and I've tried to cover everything I can into two videos. So let's start with the case. A 45-year-old man presents into the emergency department with severe epigastric pain radiating to the back for the past 6 hours. The pain started suddenly and is associated with nausea and vomiting. He reports frequent alcohol consumption, so this is something important for us, frequent alcohol consumption, drinking 6 to 8 beers daily for the past 10 years. His vital signs are 99.5, which is somewhere around normal, and blood pressure is also normal. He's slightly tachycardic, respiratory rate is also normal. Physical examination shows epigastric tenderness without rebound or guarding. Basically, rebound or guarding, I talk about this in my appendicitis video, but we'll talk a little bit about this in this one too. Bowel sounds are present but diminished. No scleral icterus is noted. Basically, no yellowness of the eyes. Sclera of the white of the eyes, icterus means yellowing, so no yellowing of the eyes is noted, so no jaundice. WBCs are 14,000, so they are up. Serum amylase is again up. Lipase is again up. ALT is slightly high, and so is AST. Total bilirubin is around 1.2 and calcium is 8.5. So let us start with the case itself. So what is the etiology of acute pancreatitis? So to remember the etiology of acute pancreatitis, we will use this mnemonic that I used when I was in medical school, which is I get smashed. I get smashed. What is I get smashed? Well, the I stands for idiopathic. A lot of the times we don't know why acute pancreatitis is happening. So it's idiopathic. Gallstones. This is the number one cause. This is the number one cause of acute pancreatitis. Gallstones. And usually when gallstones are happening, the ALT that you will get on the test is greater than 150. And we'll talk about this more as well. Then ethanol. This is the second most common type. And whenever you have ethanol or alcohol drinking as a cause of pancreatitis, you might have, because in alcoholics, AST and ALT are both high, and usually the AST is higher than the ALT. Therefore, this ratio might be twisted in a way that AST is higher than ALT, which might clue you in that this person might be an alcoholic, and this is a case of alcoholic pancreatitis. And this is the second most common cause. The third most common cause is, of course, idiopathic. The third most common cause is idiopathic. So remember the mnemonic, I get. So what does the T stand for? The T stands for trauma. The T stands for trauma. Trauma can lead to pancreatitis. We'll talk about the pathophysiology in a bit. But steroids, remember, this is a very commonly tested side effect of steroids, and a lot of the time this comes up in your exams. And also know that a lot of people are actually on steroids, and this is an important adverse effect of steroids to know. Along with another highly tested side effect is also psychiatric dysfunction, that steroids can lead to psychiatric irritation basically. Then mumps cause a lot of infection, which is meningitis, orchitis, and pancreatitis. So usually meningitis, orchitis, which is infection of the testes, and pancreatitis. So the mnemonic that we use is MOP or POM. Then autoimmune diseases, particularly IgG4 related diseases, which is important for you to know, is something called Riedel's thyroiditis. Riedel's thyroiditis is when your thyroid is very, very hard and you're getting thyroid infection. So just remember this about autoimmune infection. Remember, you're following the same mnemonic of I get smashed till now. SMA, what's the next S? The next S is sulfa drugs. I've included only the most important and highly tested things into this, and things that will come up in your wards as well. So sulfa drugs are an important cause. Then hypercalcemia, hypertriglyceridemia, and hyperchylomicronemia. All of these causes lead to pancreatitis. Then ERCP. ERCP is one endoscopic retrograde cholangiopancreatography. What you do is that you push an endoscope down, and then you push an endoscope down into the CBD through the duodenum, and that is endoscopic retrograde cholangiopancreatography. And this is one of the ways in which you can visualize and also treat pancreatitis and the CBD. Then drugs, and the most important drugs that I want you to remember is loop and thiazides, because a lot of people are on it. And then also HIV treating medications like NRTIs and protease. Remember, these are some of the most important causes that I've included here. Now what I want you to understand is this is not the most comprehensive list on the causes of acute pancreatitis. There are some other causes as well. For example, drugs such as GLP-1 analogs, azathiopurine, and anti-epileptics like valproate can also cause pancreatitis. Similarly, scorpion stings, posterior duodenal ulcer ruptures, and just the problems within the anatomy of the pancreas itself can also cause acute pancreatitis. For the purposes of this video and for the purposes of your wards, it's very important to know these most important causes, which are the I get smashed causes. So, what's the pathophysiology of pancreatitis? First of all, how is it named? Basically, inflammation of the pancreas. This means the pancreas, and itis just means inflammation in Greek. So pancreatitis is inflammation of the pancreas, and pancreas is this organ which lies near your duodenum, closely hugged by the duodenum. Then what do we have? So what's the pathophysiology among all of these causes of pancreatitis? It's all very, very similar. You get the activation of enzymes in the pancreas. These enzymes are not supposed to get activated in the pancreas. They're supposed to get activated outside the pancreas, in the intestine. So when they enter the intestine, they're supposed to get activated. There's an enzyme called trypsinogen, which is in an inactive form. It gets converted into trypsin, which is the active form. But when this happens inside the pancreas, why does this happen inside the pancreas? This is where all of those causes come in. The I get smashed causes like gallstones, drugs, toxins. These cause that enzyme to get activated early inside the pancreas. What does that lead to? Well, you lead to breakdown of the tissue. These enzymes are amazing at digesting our food. They're amazing at digesting protein, fats, every type of soft tissue. So that's exactly what they do. They start destroying the pancreatic tissue. And this destruction of the pancreatic tissue leads to what we call pancreatitis, inflammation of the pancreatic tissue. Now let us talk about the sequelae of acute pancreatitis. You get a movie and then you get its sequel. So exactly like that, you get acute pancreatitis and then you get the things that happen after it. What are those things? The most important thing to remember is capillary leakage. This is one of the most deadly sequelae of acute pancreatitis. How does it do? So cytokines, these cytokines that are released due to inflammation. Remember, cytokines are the molecules that mediate and cause inflammation, and inflammation causes the release of cytokines in turn. So cytokines, vasodilation, and as well as capillary leakage. This capillary leakage causes the shift of fluid into the interstitial or empty abdominal spaces and other empty spaces in your body. You have the shift of fluid out of your capillaries. What would that lead to? Fluid, and particularly water, that will lead to hypotension, decreased blood pressure, and therefore you can get hypovolemic shock. Even though the amount of fluid in your body is okay, that fluid is moving out of your blood vessels and into interstitial empty spaces. It can also lead to pancreatic necrosis. Well, of course, there are enzymes that are eating up the pancreas itself, so definitely it can lead to pancreatic necrosis. What else can it lead to? It can lead to hypocalcemia. What is hypocalcemia? Decreased levels of calcium in your body. How does it happen? Well, I also told you that hypercalcemia can cause acute pancreatitis. Once you have acute pancreatitis and the lipase starts breaking down the fat into free fatty acids, those free fatty acids have the ability to bind calcium in a process called saponification. And I'm not going to write the whole thing here, but saponification then leads to hypocalcemia. This leads to hypocalcemia. This is one of the sequelae of acute pancreatitis. features of acute pancreatitis. What are the clinical features which include the signs and symptoms of acute pancreatitis? The first thing, of course, the first and most important thing is the constant severe epigastric pain, that constant severe epigastric pain, this pain, that stabbing pain that radiates towards the back, and the patient will come in wheeled into the ER complaining of this pain, that there is this pain that's coming from the front, goes to the back, and when I sit up, and this is worst after meals, and when I sit up, this gets relieved. Move forward to relieve. It's worst after meals. This constant stabbing pain is characteristic of acute pancreatitis. Remember, severe epigastric stabbing pain that goes from the front to back for acute pancreatitis. What else can you have? You can have nausea, you can have vomiting. What else can you have? You can have fever, because there's active inflammation and there's the release of those cytokines and interleukins like the IL-1 interleukin, which causes inflammation and fever. And of course, you can have chest pain and dyspnea if you're getting those pulmonary symptoms. Why would you get those pulmonary symptoms? Because I told you there's capillary leakage and vasodilation that is occurring in your body, which causes the leakage of fluid into the lungs, into the pleural cavity. Therefore, the patient might find it difficult to breathe, getting that dyspnea and chest pain sensation. What are the signs? Well, on abdominal exam, you can find tenderness, definitely, because the patient is in a lot of pain. There's active inflammation in that epigastric region of the pancreas. So if you press it down, definitely you'll find pain. If you're trying to press it down, the patient will try to stop you from pressing it down and try to tense up their abdomen for you to be not able to press that hand down into their epigastric region. Therefore, this concept is called guarding, where the patient involuntarily tenses up their abdomen for you to not cause pain, and they will do something like this. Try to tense up their abdomen. And then ileus, what is ileus? Remember, ileus is something like a functional bowel obstruction. When the motility of the bowel gets disturbed, there is less motility, no movement inside the bowel. This is something called a functional obstruction, meaning even though there is no physical thing blocking the bowel, the colon or the intestines itself, there is the movement inside that bowel is so reduced that it's almost obstructed. This is called ileus. And why does it happen? Ileus always happens when there is some sort of a problem, when there is some sort of electrolyte disturbance, when there's some sort of infection, stress occurring in your body after surgery. Therefore, you have ileus, and this is pancreatitis, and pancreatitis is causing all of that capillary leakage, is causing the patient a lot of nausea and vomiting. Therefore, definitely you can have electrolyte disturbance, and definitely you will have that functional obstruction called that ileus. Obviously, you won't have this all the time, but you might have it in patients. And then ascites, you might have ascites. How do you have ascites? Again, it's the capillary leakage which causes the fluid to move out into those empty cavities like the abdominal cavity and cause you to have that filled up abdomen called ascites. What are some other signs you can see? Tachycardia, increased heart rate because the patient is in a lot of pain, and definitely there is some inflammatory thing happening in your body. Hypotension, decreased blood pressure. I told you already how that happens, again due to capillary leakage. Then less or no urine. Why less or no urine? Because your body might be going into hypovolemic shock. That fluid is moving out of your blood vessels. Less fluid is now reaching the kidneys, and the kidneys are now thinking the RAAS system, the renin, angiotensin, aldosterone system now gets activated and trying to push in as much fluid as you can into those blood vessels. So it's making very less or almost no urine, and you might have damage to the kidneys themselves when you start getting hypotensive, What else can you have? You can have jaundice, and this varies definitely on the cause of pancreatitis. So if this is the pancreatitis, the common bile duct is coming here, and if you have something blocking, if you have something like a stone or something like a cancer or anything, a problem with this muscle right here that is blocking this exit of this, therefore you have blockage of that bile, and that bile will start building up in your body and therefore cause scleral icterus, yellowing of the eyes, and jaundice, because buildup of bilirubin is happening and CBD is being blocked. What other signs can you see? Well, on chest exam, you can find signs of pleural effusion. What is pleural effusion? Basically, in that pleural cavity, between those pleura, you have fluid building up. Again, free cavities, fluid moving out, capillary leakage causing the buildup of fluid. What else can you get? You can get ARDS. What is ARDS? ARDS is acute respiratory distress syndrome. How does it happen? Well, you have a lot of inflammation in your body, you have a lot of cytokines being released, and then you have a lot of fluid that is coming out into the lungs, a lot of fluid that is building up into the lungs. What that does is, what is ARDS? It's nothing but acute respiratory distress syndrome. Why are you getting acute respiratory distress syndrome? Because there's a lot of water, there's a lot of inflammation inside the lungs. And what is that causing? That is causing that exchange between oxygen, between the blood and the lungs to actually decrease. And that is why you're getting ARDS, due to the buildup, due to lots of fluid and inflammation in the lungs. Then what is this sign? This sign where you have this blood clot or blood hemorrhage near the umbilicus is called the Cullen sign. And how this happens is retroperitoneal hemorrhage. What is retroperitoneal? Retroperitoneal, when you have an organ that is covered on only one side with the peritoneum. And for the case of the pancreas, for most of the pancreas, excluding the tail, most of the pancreas is covered only on one side by retroperitoneum. So most of the pancreas is actually retroperitoneal, but only the tail is not retroperitoneal, because it is in contact with the spleen. It is in contact with the spleen, and the spleen is, because a spleen is covered by peritoneum, is a peritoneal organ. Therefore, the tail of the pancreas is also completely covered by peritoneum. So therefore, if you have hemorrhage occurring here, you might see retroperitoneal hemorrhage like near the umbilicus, or in other spots like in the flank. In the flank, where the hemorrhage itself is being contained on one side, is being contained by that peritoneal covering, and you see this flank hemorrhage called a Gray Turner sign. Hemorrhage near the umbilicus retroperitoneally is called Cullen sign. This thing, flank hemorrhage seen in acute pancreatitis, is called the Gray Turner sign. Now let's move on to the diagnosis of acute pancreatitis. How do we do it? For the diagnosis, you need 2 out of these 3 criteria. One is that severe epigastric stabbing pain that we just talked about, that goes from the front to the back and is improved by leaning forwards and worst by after having meals. And then pancreatic enzymes. What are those pancreatic enzymes? Like amylase and lipase elevated up to 3 levels of the upper levels of normal. So if the upper level of normal is, let's say, hypothetically 50, if you're getting 150, then that is diagnostic based on this criteria. Amylase and lipase are the enzymes. Remember, lipase is more specific for pancreatitis. Amylase can be also raised in stuff that is going wrong with the salivary enzymes, because the salivary enzymes also release amylase. Lipase is more sensitive and specific for acute pancreatitis. Imaging. And the third criteria is imaging that supports the diagnosis of acute pancreatitis. When imaging supports the diagnosis, so you need at least 2 out of these 3 criteria. You get that severe epigastric pain, a raised pancreatic enzyme, and then on imaging you need to support the diagnosis. So what is the imaging? Well, you can do ultrasound abdomen, which is the first line imaging for acute pancreatitis. It's the first line imaging for acute pancreatitis, and it's best for suggesting biliary pancreatitis. How does it do that? Well, for example, if you look at the pancreas right here, this is the pancreatic duct, this is the CBD. Let's assume this is the duodenum, and the pancreatic duct is opening somewhere around here. So right around here, if you're having a stone, this causes a dilation of the CBD. What else can we do with an ultrasound abdomen? But they can also tell if there are gallstones or biliary sludge, which is just thick bily fluid that is present inside the gallbladder, which shouldn't be present. It should be just a plain old simple, very liquidy bile, but you're getting that biliary sludge which is like mixed with stones. So that is very characteristic of biliary pancreatitis. And therefore, ultrasound abdomen can tell you the cholelithiasis, which is basically just stones in the gallbladder, and dilated biliary tree, which I talked about. If there's a stone blocking here, you'll get dilation of the biliary tree. Imaging, ultrasound abdomen will show you findings like enlarged hypoechoic pancreas, basically edema in the pancreas, hypoechoic. What do we mean by hypoechoic? Meaning it's not taking up a lot of those sound, it's not taking up a lot of those sound waves. What is hyperechoic? Things are very dense, things like tissue, things like stones are usually hyperechoic. Those stones that are seen in the gallbladder are hyperechoic. Hypoechoic is usually fluid like edema. What else? You can see peripancreatic fluid. Again, it's the pancreas itself. You're seeing fluid, it's around the pancreas itself because there's inflammation that is occurring around the pancreas. Those fats are being emulsified. Then you get CT abdomen with contrast. Why do we get it done? Well, we get it done with diagnostic uncertainty. If you're uncertain what is the cause of this acute pancreatitis, like in a lot of the cases when you're not sure if this is biliary pancreatitis or not, you get it done, CT abdomen with contrast. Or you're getting that deterioration, in the patient and you're unsure whether this is pancreatitis or not. You're trying to resolve the pancreatitis, but this pancreatitis is not improving and this patient is getting worse. You should get a CT abdomen with contrast. Or it's very, very severe. You did some diagnostic, you used some severity criteria and you just found out that this patient might actually be having severe pancreatitis. Therefore, you need to get CT abdomen with contrast. Now let us talk about the findings seen on CT abdomen with contrast on this CT abdomen. What are the findings in acute pancreatitis? These findings include pancreatic edema. So you'll get the pancreas will grow bigger. It will look bigger, that there'll be edema inside the pancreas itself. There can be fat stranding. What is fat stranding? So normally on a CT, fat is supposed to look black, black, black. But when you get fat stranding, it turns sort of grayish, and around whatever organ there is inflammation, you'll get that sort of stranding, this ragged appearance of the fat itself. And I'll show you this in a bit on the CT. And then of course you can get necrosis. Normally soft tissue is supposed to look gray, but if that shows decreased enhancement, but that turns darkish, meaning you're getting necrosis inside the tissue itself. So this is how a CT of a normal pancreas should look. This is the normal pancreas. Remember, we are looking at an axial section. This is the patient's left side. You're like standing on the patient's foot end. This is the patient's left side. This is the patient's right side. This giant organ right here is the liver, and this right here is the bowel. This again is the bowel. This is the kidney. These are the vertebrae, and this lizard-like thingy right here, this snake-like thingy right here is the pancreas. This is the pancreas, and this is how a normal pancreas should look like. And as I told you, gray, this right here, this black thingy is fat. This right here is fat, and I'm sure there's a lot of fat that is hiding around here as well, but it is black. Soft tissue right here is gray. This is gray. Bone is white. These are the ribs. So this is white. This is also white. This looks gray and beautiful. And now let us look at a bad CT abdomen. This is a bad CT abdomen. Now you can see there's a lot of gray around here. There's this enhanced grayish appearance that is in this CT. This right here is what you see is the concept of fat stranding. And now the pancreas itself also looks a lot bigger. That is edematous. It is inflammation. This is inflammation. It is edematous. This is an edematous pancreas. So this is how a CT will look in acute pancreatitis as opposed to the normal we just saw in the last picture. The next imaging that we're going to talk about is MRCP. And when do you do MRCP? That's when you're suspecting a stone in the biliary tract, and the ultrasound was inconclusive. Whether in telling you whether this is biliary pancreatitis or not. Therefore, you do an MRCP, or magnetic retrograde cholangiopancreatography. Just don't remember the very hard word. Just remember MRCP. What are the other indications? Well, you can also remember pancreatic duct pathology. There might be something wrong with the duct itself of the pancreas, which is causing pancreatitis or autodigestion to happen here and leading to pancreatitis. What else can there be happening? Pancreatic cancer. Remember, there might be a tumor blocking this place, which could be causing recurrent pancreatitis in this patient. And we usually do this for recurrent pancreatitis. That's when we do magnetic retrograde cholangiopancreatography. Then endoscopic retrograde cholangiopancreatography. What are the indication? Again, stone in the biliary tract, again pancreatic duct pathology, pancreatic cancer, but this time it's endoscopic. Magnetic is from the outside, endoscopic meaning it moves inside your body. Remember, ERCP can also cause pancreatitis. It can also cause pancreatitis because you're meddling around with the pancreatic duct so much, you can actually cause pancreatitis. But if there's a stone lodged, if there is a stone lodged somewhere around here, you can also displace it. You can move it, you can take it out. with the help of ERCP. Therefore, this is also a therapeutic procedure. Nowadays, we prefer MRCP because it's non-invasive. But ERCP is also therapeutic. If you think that there's a stone lodged somewhere around here, you can use ERCP to actually take the stone out and remove that obstruction. If there is a tumor around here, you can take biopsies using ERCP. You can put a stent around here and create a pathway for the bile to flow out. That's why ERCP is therapeutic. So now let us talk about the approach while we are managing acute pancreatitis. We'll talk more about the treatment in our next video, but right now I want you to tell the approach. When you get a patient with acute pancreatitis, what do you want to do? You want to establish the diagnosis first. You use that 2x3 criteria, get those imaging results. So whether you have pain, whether you have elevated enzymes, and whether imaging supports the diagnosis, and you get that 2x3 criteria, then you want to identify the severity of this pancreatitis. You want to identify the severity of pancreatitis. Why? Because you want to treat this patient based on the severity of the inflammation itself. Then you evaluate the underlying etiology, and this goes back to those I get smashed etiology causes. So you want to evaluate the underlying etiology and maybe treat that underlying etiology so you don't get recurrent pancreatitis. So for now, let us talk about identifying the severity. In my next video, I'll talk about evaluating and treating each particular etiology of acute pancreatitis and how do you go about it. So for the severity of acute pancreatitis, there are a lot of scales, there are a lot of things that are available on the internet that you can actually use. And one of those criteria that was actually very frequently used was Ranson's criteria. And the problem with this criteria was that you take a full 48 hours to complete this, for you to complete this criteria to actually get the score that you need to assess the severity. Now what I could do is that I could include that in this video and make this video even longer, but I actually added another criteria which is actually very simple to understand and also simple to apply on the spot while you're standing at the patient's bedside, which is the BISAP score, which is bedside index of severity of acute pancreatitis. And it's very, very simple. You can use it on the patient's bedside. You can get those labs in. You can use it as soon as possible as you have the patient's lab by your side. So what do you have? Firstly, you have BUN greater than 1.9. What is BUN? BUN is blood urea nitrogen. When does your body retain it? Your body tries to retain it when your kidneys are not excreting it as much. Why are your kidneys not excreting it as much? Because the amount of fluid in your body might be going low. So your kidneys are trying to retain it, which is leading to these high BUN levels. This is bad. This is indicative that you might be having something severe occurring in your body. So this gets you 1 score. Then impaired mental status. Definitely. Remember, your body tries to preserve your brain at all times. Your body tries to preserve the mental status at all times, tries to give as much blood to the brain as possible. So if you have impaired mental status, that is bad. That usually indicates a severe pancreatitis. Then systemic inflammatory response syndrome. Basically, you're getting all of those symptoms, and you can go look at this up, and I'll talk about SIRS in my next video on acute pancreatitis management as well. But if you have SIRS, that gets you 1 point. And age greater than 60 years, having an age greater than 60 years already predisposes you to the mortality of acute pancreatitis. People who are of higher ages usually have severe and bad pancreatitis, and the mortality is higher. And then definitely pleural effusion on X-ray. And what each of these predicts adds up to be 1 point. You give 1 point to each of these. And if you have a 0 to 2, this is a less severe, low mortality group. The overall mortality is less than 2%. And as soon as this score increases to 3 to 4, this mortality starts increasing to greater than 15%. I like this BISAP score really much because it's very, very easy. It's something that you can do very easily off the top of your head. You can do, as you said, bedside index of the severity of acute pancreatitis. Therefore, I use it. So what's the takeaway from this lecture? Pancreatitis is inflammation of the pancreas. What is the etiology? Well, the etiology is idiopathic, gallstone, ethanol, and trauma. Gallstone are the most important cause, ethanol is the second most, and idiopathic is the third most important cause. And then steroids, mumps, autoimmune diseases like IgG4 related disease, particularly like renal thyroiditis. I'm repeating this again because if something like this, if something obscure like this comes on the exam, I want you to know this. Then sulfur drugs, definitely very important for the wards as well. Hypercalcemia, hypertriglyceridemia, and hyperchylomicronemia. These two are especially important, and I'll talk about their management in the next video as well. And then ERCP, very important. This procedure is done very frequently. And then drugs. ERCP is also used for the treatment of acute pancreatitis as well. If you think there is biliary pancreatitis, if there's a stone coming in and blocking that pancreatic duct. And drugs like NRTIs, protease inhibitors, and very, very important, loop and thiazides. Similarly, you can have other drugs like anti-epileptics and GLP-1 analogs as well, and azathioprine that can cause pancreatitis. What's the pathophysiology? You get premature activation of the enzyme that leads to pancreatic destruction, that leads to inflammation, which is pancreatitis. What's the sequelae? The most important sequelae is vasodilation plus capillary leakage. You get the cytokines in the blood which lead to hypotension and can lead to shock. This shock can be very, very deadly. This shock can be very, very deadly. This is me trying to make a skull, but I did a horrible job at it. But other sequelae is hypocalcemia, the free fatty acids that are released by the breakdown of the fat, of the peripancreatic fat around the pancreas, binds the calcium and leads to low calcium in the body. Remember, hypercalcemia can cause pancreatitis. Pancreatitis can cause hypocalcemia, which is low calcium. Then necrosis as well. What are the clinical features that I want you to remember? Remember, stabbing epigastric pain, very, very important, goes front to back, is relieved when you sit up and lean forward, and worse after meals. You have fever and nausea. And then, of course, you can have vomiting. What are the signs that I want you to remember? Remember epigastric tenderness. Remember the Gray Turner sign for the purposes of your exam, not so much for the wards. And then the Cullen sign, and also that guarding that I talked about, when the patient involuntarily tenses up their abdomen for you to not push in their abdomen. And then jaundice, of course. This is very important for you to remember. If there's something blocking the pancreatic duct, if there's something blocking the confluence of the pancreatic and CBD, therefore you're blocking the bilirubin, and that bilirubin is now building up in your body, and therefore you can get jaundice. Remember, for the diagnosis, you follow the 2x3 criteria of epigastric pain, elevated enzymes up to 3 times the upper level of normal, 3 times the upper level of normal, and then of course supporting imaging. For imaging, ultrasound abdomen is the first line, particularly why? Because biliary pancreatitis is the most common type of pancreatitis. Most commonly it's due to gallstones. Therefore, this is great for visualizing gallstone and bile duct dilation. When do you do CT? Well, you do CT with contrast, for when there is severe pancreatitis, you are suspecting deterioration and there is diagnostic uncertainty. What else? You can do an MRCP, ERCP. MRCP is great, non-invasive, can be done from the outside, can tell you if there's a stone in the biliary trunk that you can't see, can tell you if there's a duct pathology or if there is cancer. ERCP is therapeutic as well. You can take a biopsy, you can take that stone out. For the severity, you use the BISAP score. There are other scores like Ranson criteria, but they take more than 48 hours. You can use the BISAP, which is the bedside index of severity of acute pancreatitis score, where the BUN is greater than 8.9, meaning your body is trying to retain the blood urea nitrogen. And then impaired mental status, you have bad mental status, SIRS, systemic inflammatory response syndrome, and then age greater than 60 years. And then pleural effusion. Each one of these scores is bad, is indicative of high mortality. Each one of them get 1 score. If you have a score greater than 3 to 4, you're getting almost 10 to 15% mortality. So in the end, let us look at that case again. A 45-year-old man presents to the emergency department with severe epigastric pain radiating to the back for the past 6 hours. So severe epigastric pain goes from front to back for the past 6 hours. Pain started suddenly and is associated with nausea and vomiting. He reports frequent alcohol consumption, drinking 6 to 8 daily for the past 10 years, 6 to 8 beers. His vital signs are he does not have fever, does not have blood pressure high, just has slight tachycardia. It's greater than 60 to 100, so it's 105. And then respiratory rate is around 18. Physical examination shows epigastric tenderness without rebound or guarding. Bowel sounds are present but diminished, and no scleral ictus, so no jaundice. What is the most likely cause of this patient's condition? What is this? Gallstone obstruction of the CBD and chronic alcohol use, hypertriglyceridemia, medication-induced pancreatitis, autoimmune pancreatitis. Now, if we can look at each one of these causes. Autoimmune pancreatitis, whenever they give you someone with an autoimmune pancreatitis, they'll give you sometimes like a 30-year-old female, and they will give you someone with a history of some sort of autoimmune disease, or they will tell you that their brother or their sister has some sort of autoimmune disease. So this is likely not autoimmune induced pancreatitis. Medication induced pancreatitis, they will tell you that the patient is taking some sort of medication like those steroids, azathioprine, anti-epileptics, NRTIs, sulfa drugs, loops, thiazides, protease inhibitors, something like that. We had nothing of that sort. Hypertriglyceridemia, they will tell you that the patient has a very high BMI, or the patient was on statins and is not taking statins, whatever. They'll give you something of a comorb of hypertriglyceridemia. So I won't put this very high. Chronic alcohol use, well, this patient does have chronic alcohol use. Gallstone obstruction of the CBD, or just caused by biliary pancreatitis caused by gallstone, both of these options are correct. And in difficult exams, they give you two very similar options. But for the purposes of your exam, because they were trying to build up that picture of someone that is an alcoholic who drinks a lot of beer, I will choose for the purposes of this question chronic alcohol use, but definitely this answer is also correct. In the end, thank you so much for watching. Work hard, be kind, and amazing things will happen. This is a quote by Conan O'Brien, who is my personal favorite. So thank you so much.